So I'm the principal investigator for the All of Us research program at Xavier. I'm also a principal with 7-Star Academy, which is a nonprofit organization my husband and I started some years back. And so we're also funded as well. So the All of Us research program acknowledges, so there's some definitions. Engagement is a broad range of relationship building, bidirectional interactions, including information sharing, consultation, collaboration, and decision making, and empowered action between the program people, awardees, and other partners. So we're doing engagement. I'm not doing outreach. Outreach is unidirectional interactions, such as providing materials and information to an audience. And lastly, recruitment is facilitating enrollment into the program. So outside at the table, we have a table set up. There's material to learn more about the All of Us research program, because some of it will begin to answer some of the questions that came up earlier. So I don't want to hold, but we'll talk more as we go forward. And this is the All of Us research program. I want you guys, we're going to listen to this video.
What we've done in medicine over the years has not really taken into account individual differences. This is an opportunity to be part of something historic.
Most studies and most clinical trials have always been with the average white male. So as we start thinking about this in the context of building trust, I think we get back that trust by involving the community, not saying you come to us or we'll just do things to you. We're going to do things with you and in fact, allow that information to be accessible to you, the individual.
You're going to have some individuals that are going to say, yes, good, we're getting in on the ground level of a study. And then you're going to have those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input and, without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened. We're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that, whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer, or heart disease, communities of color are disproportionately impacted by them.
It has always been playing catch up to make sure that they're even getting access, much less minimum service. Low income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who is never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
Now that you've been introduced to All of Us research program and the nexus of it, this gentleman here is Dr. Francis Collins, who was the director who initiated the All of Us research program that is funded by the National Institutes of Health. Now, I got to meet and actually have lunch with Dr. Collins when, so we're back some 15 years back, when the human genome was completed, the sequencing of it was completed. He was then the director of the National Institute for the Human Research Institute. And he led not just the nation, but the world to actually sequence the human genome that is deposited in the National Library of Medicine. And all of us who pay taxes, everybody in the room pays taxes. So we all paid for this work to be done. It was done with 600 other nations. He led the United States led that initiative. And so when I had a chance to talk with him, I asked him whose genome is it anyway? Because it's one person's DNA that is sequenced. And the significance of that is that all the drugs on the market, some drugs that Dr. Sarr talked about, drugs that are on the market, you've seen Humiras and Stellaras and all of these new cancer drugs that are arriving, they're made using a human DNA template to make them. So my question was, whose DNA is that? And he told me it was a 40-something-year-old Caucasian male. And I said, wow, well, I don't look anything like a 40-something-year-old Caucasian male. He said, well, we had to start somewhere. They brought in some 400 Caucasian men that live in the DC, Virginia, Maryland area, invited them to come in. They all donated their biospecimen. They randomized the biospecimen. I guess they did eeny, meeny, miny, mo, and picked one. So whoever was in the room doesn't even know. That's what he said to me at that time. Doesn't even know whose DNA it was. And so that is how the human genome was sequenced. And it serves as the reference DNA for everybody around the world.